Okay, so for the last time we were talking about the forearm, and we basically divided our forearm into three compartments. There was an anterior compartment, posterior compartment, then a lateral compartment. Right? And in those compartments, we saw muscles. And those muscles were basically saying they were going to insert into the hand, most of them. So we want to see how those muscles pass into the hand. Right? And that's when we look at this region known as the wrist. So for us to be able to understand this wrist region, you need to have a prerequisite knowledge of the forearm. Right? So in the region of the wrist, we have what we call the carpal bones. Right? And if we were to come back to the bony anatomy, this is the carpus made up of 8 bones. Right? So there's the scaphoid, the lunate, triquetrum, pisiform. This is from lateral to medial. So we say she likes to play. Scaphoid, lunate, triquetrum, then the pisiform. Then the distal row also has 4 bones, unlike in the foot where the tarsal bones will be 7. These are 8. So for these ones, we are going to say the distal ones, try to catch her. So trapezium, trapezoid, capitate, and the hamate. Right. So in the region of the wrist, right, we have what we call retinacular. The purpose for retinacular is to bind the tendons down, because you have tendons going into the hand, and those tendons can be mobile, but to prevent their mobility, we have these extensions of deep fascia that we call retinacular. I'll have the same arrangement when I do the ankle region in the lower limb. The anterior forearm was the flexor compartment. So on the anterior wrist region, there is the flexor retinaculum. The posterior compartment was the extensor compartment. So on the posterior wrist region, there will be an extensor retinaculum. So we come to this very beautiful picture that I want to use. This is flexor retinaculum on the front. Right? So flexor retinaculum on the front. Then I have extensor retinaculum on the back. Right? So I'll start with the flexor retinaculum because this is the one that is more important. So the space that is between the flexor retinaculum and your carpal bones here, the bones of the carpus, the ones that I was saying she likes to play, try to catch her. We call this space the carpal tunnel. Right? The carpal tunnel is important because there is a nerve that passes from the forearm into the hand within this carpal tunnel. Right? So we have this nerve here. And this nerve is what we call the median nerve. If you remember, the median nerve was the nerve for the anterior forearm, but it's going to pass into the hand below the flexor retinaculum here, within the carpal tunnel. Right? So you can have injuries of the median nerve in that region. Have you guys done endocrine physiology?
No.
You haven't. Okay, okay, it's fine. But any form of trauma or metabolic disease or whatever that will cause this flexor retinaculum to move towards the bone will compress everything in this carpal tunnel, and we get something called carpal tunnel syndrome. Right? So carpal tunnel syndrome is because, or is as a result of compression of the median nerve here in this carpal tunnel. So I'll just think about where the median nerve is going. So I will affect the muscles and the skin that are going to be innervated by the median nerve after this carpal tunnel. If I compress the carpal tunnel in the region of the wrist. So if you compress median nerve there, you have manifestations relating to median nerve entrapment. When we go to the lower limb, there will be something called tarsal tunnel syndrome. And so for tendons that pass below the flexor retinaculum, I just need to think of tendons that are in the anterior forearm. Right? I remember telling you that there are 8 muscles in the anterior forearm. There are 4 in the superficial, the ones that I said PF, pronator teres, flexor carpi ulnaris, flexor carpi radialis, and palmaris longus. So I need to know, of those 4 tendons, are any of those tendons going into the hand? If so, do they pass below the flexor retinaculum within the carpal tunnel, or they go above it? Right. So the first muscle was pronator teres. It ends near the elbow joint, so it doesn't get to the wrist. So I'm not expecting to see pronator teres here. Then the other muscle is flexor carpi ulnaris. Right. For the purpose of description, flexor carpi ulnaris is not related to the flexor retinaculum. So it neither passes below nor pass above it. So I don't expect to see it here. But when you see the description of the wrist, the flexor carpi ulnaris is the most medial structure. It will be somewhere here where I'm going to shade here. It's the most medial structure at the wrist. But it doesn't pass above, it doesn't pass below the flexor retinaculum. That's 2. Muscle number 3 is the flexor carpi radialis. Right. This one also doesn't pass above nor below. I want to show you something. This. Can you see that this is the flexor retinaculum? And we're saying there are things that are going to pass below in this carpal tunnel. There are things that are going to pass above it. But can you see that there's a hole here in the flexor carpi, in the flexor retinaculum? That hole is for the tendon of the flexor carpi radialis. So flexor carpi radialis will pass in a split or in a gap that you find in the flexor retinaculum. Right. So here, this is flexor carpi radialis. It passes in a split. Right. Then, so we now have 3 from the spatial group. The 4th muscle was palmaris longus. Palmaris longus, in terms of insertion, palmaris longus inserts into the flexor retinaculum as well as into the palmar aponeurosis on the hand. So this is the tendon of palmaris longus, ladies and gentlemen. It passes on top of the flexor retinaculum. I don't have a tendon from the superficial group of the anterior compartment muscles passing below the flexor retinaculum. It's either they don't reach the wrist, they don't pass on top or below, or there's only one, the palmaris longus, which will pass on top. The rest of the muscles that are left in the anterior compartment of the forearm, that is superficial and deep. No, not superficial, intermediate and deep. I've just told you the superficial, intermediate and deep. They'll pass below the flexor retinaculum. So intermediate for the forearm, we said there was flexor digitorum superficialis. Flexor digitorum superficialis, we said it has to go and insert into the medial phalanx or the medial phalanges of the hand. So I should see the 4 tendons of flexor digitorum superficialis here. Right. It is described to say that the 4 tendons are not at the same level. Then you can see it here. The 2 middle ones are anterior, then the 2 outer ones are a bit posterior. Right. Then if you go into the deep compartment of anterior forearm, there were 3 muscles: flexor digitorum profunda, flexor pollicis longus, then pronator quadratus. Pronator quadratus, just like the pronator teres, does not enter the hand. So I don't expect to see a tendon of the pronator in the wrist. Otherwise, flexor pollicis longus is this one. Then this is the tendons of flexor digitorum profundus. But to tell you the truth, the reason why carpal tunnel is important, like I said before, is because the median nerve passes through it. And as it passes through the carpal tunnel, the median nerve can undergo what we call nerve entrapment. If you trap the nerve between the retinaculum and the bone and you compress it, you have neurological deficits relating to median nerve function. So the hand will basically not function well because that median nerve is going into the hand to innervate structures. Then other things that pass on top of the flexor retinaculum besides the tendon of palmaris longus, there is the ulnar nerve and the ulnar artery. The nerve is medial at the wrist. The artery is lateral compared to the nerve. I think if you see, this is the little thing on this side, that's the medial side. The first thing that you come across is the ulnar nerve before you get to the ulnar artery. Right. Then other things that are not included here that I'll add. On either side of the palmaris longus there, so I'm going to put 2 red dots there. On either side of the palmaris longus, passing superficial to the flexor retinaculum, there will be 2 other nerves. These 2 other nerves are going to be innervating the skin of the hand. So there is what is called palmar cutaneous branch of the ulnar nerve. Then there is what is called palmar cutaneous branch of the median nerve. So palmar cutaneous branch of median nerve, then palmar cutaneous branch of ulnar nerve. They pass superficial to the flexor retinaculum. Then when you go to the extensor retinaculum, I know I forgot to mention the attachments of these retinacula. So if you just remember, you couple bonds, right? The most lateral in the proximal row and the most lateral in the distal row. Then the most medial, hello, sorry. Hey, how are you? Okay. So I was saying that attachments for the flexor retinaculum, you just need to remember the most medial bonds. So remember the mnemonic from lateral to medial, it's she likes to play, try to catch her. So the lateral attachments for flexor retinaculum, it's she and try. So it's going to be scaphoid, then trapezium. Then the medial, it's going to be play and hair, the most medial bonds. So the pisiform and the hamate. Extensor retinaculum will have the same attachments on the medial side as the flexor retinaculum. So it's going to be the pisiform and the hamate. But laterally, your extensor retinaculum will actually not attach onto the carpal bones, but it attaches onto the styloid process of the radius. So the two retinacula have the same attachments medially, which is going to be the hamate and the pisiform. Then laterally, the flexor retinaculum will attach onto the scaphoid, as well as the trapezium. Then laterally, extensor retinaculum will attach onto the styloid process of the radius. Right. Then this extensor retinaculum, you divide it into 6 compartments, and each compartment will have a tendon. Some tendons will share a compartment. For example, this compartment here will have the 4 tendons of extensor digitorum sharing with extensor indicis. So this is one compartment with 2 muscle tendons. One for the extensor digitorum, then one for the extensor indicis. Then there is also a compartment for extensor carpi ulnaris. So there's a compartment for extensor carpi ulnaris there. Then there's a compartment for extensor digiti minimi. Basically, you're thinking about muscles coming from the posterior forearm. There's a compartment that is shared for the radialis muscles. So there's extensor carpi radialis longus and extensor carpi radialis brevis. There is a compartment for extensor pollicis longus. Then there's a compartment that is shared for extensor pollicis brevis and abductor pollicis longus. So point is there are 6 compartments. Of the 6 compartments, 3 of them are shared. The ones that are being shared, number 1, there is a compartment for extensor indicis and extensor digitorum. Number 2, there is a compartment for extensor carpi radialis longus, which it shares with its brevis, the extensor carpi radialis brevis. Number 3, there is a shared compartment for abductor pollicis longus and extensor pollicis brevis. Then the 3 that are not shared, where there's a single tendon, there's a compartment for extensor carpi ulnaris here. There's a compartment for extensor digiti minimi, that's 2. And the third one is this one. There's a compartment for extensor pollicis longus. Towards the end of the video on the forearm, the last time, I introduced something called the snuff box. The snuff box is the space that is between these two tendons that are sharing, which is the lateral boundary, which is abductor pollicis longus and extensor pollicis brevis, and this tendon here, extensor pollicis longus, which is the medial boundary. The space between them is what we call the anatomical snuff box. Because back then when people used to snuff, or I think in Shona it's called mute, it used to be put in that space, just behind your what is it? Just behind your thumb there. That's your snuff box. Within that snuff box, you can feel for the pulsations of the radial artery, which you can see here. If you put your hand there, you can feel a pulse. That's the pulse of the radial artery. In the roof, if you're quite thin like me, you can see, I don't know if you guys can see my hand. You can see a vein that is going superficial there. It is this vein here, being called the cephalic vein. Right? Other things that you can palpate for in the snuff box, if you get fractures of the scaphoid, you can palpate the scaphoid there, as well as the styloid process of the radius. Right? Then just like at the front where I also have things passing superficial to the flexor retinaculum, I should also have things passing superficial to the extensor retinaculum. And these are going to be veins. So cephalic vein on the lateral, basilic vein on the medial. I'll touch these veins with the hand because they are coming from the hand, but they are basically created from something called the dorsal venous arc. So dorsal venous arc is what creates this these two veins. The dorsal venous arc continues as the cephalic vein on the lateral side. Then on the medial side, it continues as the basilic vein. These are superficial veins that resemble the superficial veins that I also have in the lower limbs, which this time around you call great saphenous vein and the short saphenous vein. Other texts prefer to call the short saphenous vein the small saphenous vein. Right. Right. Any questions on the wrist region here? Then of course there's the wrist joint. Wrist joint is between the radius and the carpal bones, which is only the scaphoid, the lunate, and the triquetral. The scaphoid, the lunate, and the triquetral, they articulate with the radius and create a synovial ellipsoid joint, which is the wrist joint. The ulna is not part of the wrist joint. The same way when we do the lower limb, we'll find that the fibula, which is the lateral slender bone of the leg, is not part of the knee joint. So ulna is not part of the wrist joint. And when you look at the wrist joint, there is no rotation possible at the wrist joint. You can only flex it using anterior forearm compartment muscles, or extend it using posterior compartment muscles. You can adduct using any muscle in the forearm that is medial, which is flexor carpi ulnaris maybe. If you go to the back, there's extensor carpi ulnaris. Or you can abduct using any muscle on the lateral side, meaning any muscle that is pollicis in it. So extensor pollicis longus, flexor pollicis longus, or any muscle that is radialis in it. Extensor radialis longus, extensor radialis brevis. So any muscle lateral side, they abduct the wrist. They pull the wrist towards the side where they are. Any muscle on the medial side will pull the wrist medially, which is adduction. Right. So that pretty sums up the wrist region. You need to be able to identify the tendons that are passing on top, tendons that are passing below, structures that are passing on top, or be it the nerves or the arteries, for you to be able now to create clinical scenarios or clinical pictures where we describe nerve entrapments, for example, carpal tunnel syndrome. So do you have any questions so far, you guys, from what I've discussed, this wrist region? It's a pretty interesting thing. Don't not as interesting as the ankle region, but it's interesting. Any questions from that? Hello, I can see Taku, I can see Tino. At some point the meeting had 7 people. I don't know where the other 4 went.